So, if you're watching or listening, welcome to this interview with Thomas Gustavsson. My name is Jan Steunenberg, and I'm providing focused acceptance and commitment therapy training in the Netherlands for mental health professionals since 2019. And Thomas Gustavsson is a Swedish clinical psychologist. He has spent over 2 decades collaborating with Kirk Stroessel, one of the ACT founders, and Patty Robinson to elevate Focused ACT to new heights. And in September 2024, Thomas and I met during the 5-day Focused ACT Summer Intensive in Seattle, USA. And now we are thrilled to join forces for an exciting 3-day Focused ACT workshop this May 2025 in my hometown of Utrecht, the Netherlands. So I'm super excited. Thomas, thank you
So am
for
I.
having this interview, and I'm really looking forward to this incredible opportunity to bring your experience to Holland to my Dutch colleagues. So, are you ready to dive in?
I am, yes.
Nice, nice. Thank you so much. And can you start by sharing a bit about your professional background?
Yeah, as you said, I've been a psychologist for a while, like almost 25 years. So I started out in a company called Psychology Partners, Psykolog Partners. I was one of the founders. That brought me to south of Sweden, from mid-Sweden. So I live in South Sweden, Helsingborg, where I started a couple of offices of this Psychology Partners. And I was also part of starting an open psychiatric clinic for half of Helsingborg's population. So I was one of the founders of that clinic as
Cool.
well. And then, back in 2012, I think it was, I left Psychology Partners for a treatment center where we worked with young women. That was an inpatient facility. So we were working with a lot of young women who've been self-harmers. They were very often had neurodivergency, like autism or ADHD, and severe PTSD. That was kind of the main.
Yeah,
So we were working like 24/7
yeah. A
with,
lot of comorbid problems.
yes, a lot of comorbid problems. And all of these women had been into a lot of treatments before, so they were kind of considered to be treatment resistant.
Ah,
Yeah. So, and a lot of them, the first thing they said to me when they started talking, because it took a while, because the most of them have been victims of sexual assault and molestation and horrific like traumas. So,
yeah,
and I was a male, obviously, so it was kind of a little bit of a challenge for them to have a male psychologist.
yeah, yeah.
So it took a while to build trust. I had a dog at the time that was my best co-therapist.
Oh,
It was,
wow, a dog. Oh, your
yeah,
dog. You brought the dog.
she made a therapeutic alliance like smooth.
Oh, yeah, you told me about her. Yeah.
Yeah, yeah. So that was kind of a, yeah. But many of them said like, if this doesn't work, I'm going to commit suicide. I'm done with treatments. So it
Yeah.
was a lot of at stake.
Is that where ACT came in? Because at that time, ACT was used a lot for like treatment resistant
Yeah,
clients.
I started out like I read the first ACT book in 1999 when it came out, and it was like I haven't been done anything else since then. So I'm kind of a trained behavioral therapist from start.
Yeah, you got infected by the ACT virus.
I got infected, yeah. So now I'm a soup spreader, I hope. Yeah. So so I've been doing that, and I've been working as a consultant in a lot of kind of different settings as well. So parallel with working within these clinics, I've been doing supervision training and other consultant working.
Yeah. And
So
can you tell me how became did you became involved with focused acceptance and commitment therapy?
yeah, that's the thing. Working as a consultant, I mean, there's someone paying for your time. So when I kind of get into a kind of a primary care center or a psychiatric center or whatever clinic, they want to kind of use as little money as possible. So it's a kind of the business part of it. Like you want to be pretty swift. You want to kind of, and you want, as a consultant, you want to kind of do things that matters kind of early on, because you build trust, like exactly the same way you do with clients. You want to do something that kind of matters for the clients early on, so they kind of want to invest in the treatment, because they have this kind of sense that this is going to work. I think it's the same thing with kind of with people who kind of buying your time, like as a consultant, they want to see something happen. This is kind of for real. Yeah. So I started to kind of boil down things from the act, like the traditional more act model, and do, I mean, I was, at the time, I was thinking like it was cutting corners. Now I don't think that anymore. I think it's more like we kind of focus, and I think the focus has kind of a value of its own. I mean, I think that ACT is a wonderful model. I think that FACT is kind of a supercharged model. I think it's kind of the focus can bring something extra.
Supercharged ACT.
Yeah, I think so. That's kind of.
Can you tell a little bit more about what makes it supercharged ACT?
Because I mean, if you think about treatments that we know about, like we know that for people with depression, you don't start out with a kind of the cognitive interventions, or I mean, you start on with a behavior activation. You start on with things that kind of put them in touch with reinforcers, like really early on in treatment, and that's what we try to do. In fact, but not for just for depression, like every single. And sometimes getting in touch with reinforcers is not like I'm happy. This feels good. Could be, on the contrary, it could be really hard. It could be painful to get in contact with reinforcers, but because reinforcers is also connected with sorrow and loss and anxiety and demands.
It's connected.
Yeah, it's connected. I mean, it's like the two sides of a coin. Like if there's really something really valuable to a person, like this is really matters, you can be sure that also can produce a lot of pain.
Yeah. Do you have a concrete example, a specific example of getting in contact with a reinforcer that's painful?
Yeah, I mean, for a person who has kind of been hurt in relationships, like rejected, I mean, it's really hard to kind of, I mean, there's a lot of longing for connections. There's kind of longing for love or intimacy, but kind of the earlier experiences of being rejected is so painful that you kind of really don't dare to do that. I mean, hesitate to do that. You withdraw from things.
So making the first steps will cause a lot of anxiety.
Of course, yeah. And I usually kind of talk about that. I mean, one of my last clients today, who's kind of a young male, pretty suicidal. And we were talking about feeling kind of guilt, because that's kind of one of his main drivers, like is feeling guilt. And we were talking about when he kind of take care of his own needs. I mean, when he kind of do things for himself, he feel guilty, because that means that he doesn't do things for others at the same time.
Yeah.
So it's kind of connected with him. So when he take care of himself, and maybe he says no to some work demands or whatever, he feel a lot of guilt.
So
but
it's like
we're talking about that, like, you know, when you kind of, when you do something that you haven't done for a while, like go to the gym, if you doesn't do that regularly, I mean, you're going to get really sore. I mean, the day after a leg, when you're doing a leg day at the gym, you're going to be hurting. I mean, that hurts. But that's also kind of a sign that you have done something that kind of challenge your muscles, your muscle fibers.
Yes,
So
nice metaphor. So it's like this client investing in himself, doing something he likes would mean he would be willing to experience guilt.
Yeah. I mean, that's
Then
kind
he
of
gets
part of it.
reinforced when he invests by doing something he likes. Afterwards, he gets reinforced.
Yeah. But I mean, also when you can kind of reframe doing things for yourself, is kind of, you can kind of reframe, you can kind of actually count in guilt with that. So guilt will actually go from being kind of an aversive, that I can't do that because I feel so much guilt. Suddenly you can reframe that and you can kind of say that kind of the receipt that I did the right thing is that I'm feeling guilt.
Yes.
Because then I know
Yeah.
I'm doing the right thing.
Yeah, you worked.
Yeah,
Yes.
that's kind of the workout soreness.
Oh, beautiful,
Yeah.
beautiful, Thomas. And how would you explain focused act in a few sentences to someone familiar with ACT but not with focused act?
I would say that that's a tricky one because that would be the most simple question to answer. But I think it's a tricky one because it's if you think that you are trying to do ACT, but your time is limited. You only, instead of having like 10 or 12-hour sessions with this client, you see them in a kind of a context where you only maybe see them once, maybe
Mm,
twice, maybe
mm,
3 times, 4 times. You don't know that but you know that I see them now. So what we try to do is that we try to kind of streamline this first session so that you kind of squeeze in all the factors that we know are associated with powerful change and kind of change mechanism. So we go through like a whole treatment in 30 minutes, all the components. And there's a kind of a structure to that. So most of this 30 minutes is kind of manualized in a way that you can kind of track, like you can train, you can track this, you can be very good at the interviews. There's kind of 2 different interviews, but it's also going to be kind of creative parts. You need to kind of also, I mean, if you have 30 minutes, I mean, half of the session you might spend that on kind of gathering information to kind of get a picture of what's going to be in focus, what we're going to work with, what will be the main area or main areas for this client. But you also want to do kind of the intervention part. And when you do the intervention part for a client within like 30 minutes, within the first session,
mm,
you need to bring everything to the table. You need to bring that person into the present moment. You need to kind of um, push those buttons,
mm.
but you need also to kind of be able to learn skills, like new skills. What do you do when this shows up for you? So it's a kind of an active treatment, of course, since you only have 30
And of
minutes, but
course,
it's not on speed. I think that's kind of an important part. It's not on speed. This is not like a stressful event. It sounds like we're going to squeeze in a lot of things, and we do that, but we do it in kind of a structured way that it's not, I mean, it's not a stressful event. Actually, most clients, most professionals I work with that I'm training or supervising, I usually ask them, do you kind of sense that this was like stressful or on speed? And they, no, actually not. This was kind of a smooth experience.
yeah, yeah, awesome. Yeah, of course, I know what you're talking about. And at the same time, our listeners or viewers,
Yeah,
I know what they're probably thinking like,
yeah,
wow, how is this possible in a 30-minute talk, you know? So
yeah,
what would you say if people say, how is that possible?
yeah. I mean, uh, what I want to say is just come and see it. Come and train. Come and kind of check it out and evaluate it afterwards. Like,
Yes.
but because I understand those hesitations. I mean,
Yeah.
that's kind of valid hesitations.
Yeah.
How is it possible to do this kind of in a swift, smooth way
Yeah.
without kind of forcing change upon the client? I mean,
Yeah. I,
we don't try to do
I
that.
I started a focused act training, online training today with a new group.
Yeah.
I always tell my attendees of the training, like, you know, enjoy the ride. First, learn the sequence.
Yeah.
Uh, Understand what's the philosophy. Practice.
Mm.
So I can call you and you can tell me at 3 in the morning.
Yeah.
About the questions in the contextual interview.
Mm.
And then after the training, practice it 3 times and then and then give your judgment, you know.
Yeah, yeah,
Yeah, and I really like your response. Yeah, come, and for everybody who's
yeah,
thinking about, oh, it's
yeah.
in
But
English, I will translate it to Dutch. Yeah.
yeah, yeah. But I also think that, I mean, that's because that's how you kind of, it's hard to kind of explain how to do this because you need to kind of maybe see it and
Yeah.
to try it out. But
Yeah.
I also think that if you think about kind of the change mechanism that we know, I mean, we know that we need to kind of create some kind of trust. I mean, between the client and the therapist, um, like kind of a mutual agreement that this is what we're going to do. So we need to kind of actually be kind of talking about the focus. So why are you here today? What's kind of the reason that you're seeing me today? What's the main reason?
Mhm.
And we need to focus on that. We don't have a lot of time to work on kind of all of the etiology and the history, and we don't have the time to do maybe proper diagnostics. It's more like we really don't. I wouldn't say that we don't care about it, but it's not kind of the main purpose of this. This is a
Mm.
kind of like we're doing interviewing, we do kind of skills training, we do treatment planning, like change planning, and that's pretty much it. So if you kind of think that you cut out that part from like traditional therapy, it's not that weird that kind of that we can do that in 30 minutes. But if you think that we need to do all of the kind of traditional therapy moves within
Yes.
30 minutes, that's kind of crazy. You
Yeah.
can't do that.
Yeah. You need to be selective.
Yeah, you need to be
And
selective.
and what makes focused act unique compared to regular act?
I think the focus part. I think that we don't build like the treatment on like first session, second session, third session. It's not a protocol like that.
Mhm.
It's more like we cut through all of the sessions and we kind of see if we might see the client for a few sessions, that's for sure.
Mhm.
But we don't count on it. It's more like this is kind of, let's see if the person can respond to this dosage of therapy. And a lot of people can. Not,
Mhm.
I mean, not everyone, of course. There's no such thing as a treatment for all. But a lot of people, more than we think, have the capacity, the capability to actually do radical change.
Yeah.
And they can do that. I mean, they can do that in the first session, the second session, the seventh session. But most people, I mean, if we look at what happens as a clinician, if you look back at your experience of change, it's very seldom like people improve 1% per session, like over time. It's very kind of common that people kind of have this kind of whoa experience that
Yeah.
whoa, that kind
Yeah.
of changed things.
Yeah. Yeah.
And what we have done in Focused Act is that we have kind of tried to kind of pinpoint what are those moments. How can we kind of facilitate that?
How can we facilitate woe moments?
Yeah, that's it. I
Yeah.
mean, back in early 2000 when I was working with ACT, more traditional ACT, we were talking about the kind of the heart attack experience. Like you survived a heart attack and you suddenly had this, whoa, life is short.
Yes.
I really need to be kind of living my life fully
Oh,
from this day and
I
over.
love that one. I didn't hear it before, but the heart
Yeah,
attack experience.
yeah. I think a lot of people that kind of suffers from a sudden like near death experience, that kind of it kind of changed people. And we were thinking about maybe you can do that without being near death,
Yeah.
at least physical death, maybe emotional death. Yeah.
Hey Thomas, in your opinion, what makes focused act so effective for mental health professionals?
I think it's because it's a kind of in many ways it's a logical model. It's if you kind of just kind of buy into some of the kind of basic assumptions about change and human nature, and you kind of can see like there's the kind of the medical model that we talk about like more of a kind of a traditional psychiatric model for like a very biological model, and I mean symptoms are kind of symptoms of some deficit within the person,
Yeah.
and you need to work with that kind of deficit in some way, and when the symptoms kind of go away, you know that the person is kind of healthy again. Like we
Mhm.
cured him or her.
Yeah, it's like linear.
Yeah,
A
it's linear
to B.
in a way, in a way. And I think that works well. I mean, it's if you kind of looking at if you have kind of an infection. I mean, you get an infection, you get fever, you get maybe you kind of your pee smells bad and whatever, and you can make a sample from that, and you can actually see this is the kind of the bacteria that causes this infection,
Yeah.
and you can match that with an antibiotic, and you can give that antibiotic to the client, and it would kill the bacteria, and the symptoms go away, and the client is cured.
Yeah.
I mean, that's very logical. I think that, I mean, and we kind of accustomed to think that way
Mhm, mhm.
because we think about illness like this is kind of a disease or this is a kind of a disorder or
Yeah.
whatever. If we kind of put that aside, it's not a kind of a bad model, but it's just not, we have another complementary model to that. It's not kind of a better model, it's a different model. Sometimes you can work with a medical model, sometimes you can't. So what we can do is we can kind of focus on the kind of the contextual model, that it's not that kind of easy that like
It's complex.
things, yeah, it's a complex in that way that things might correlate, but they might not be causations within
Mhm,
them.
mhm, mhm.
So people, when people kind of come in and say that I'm I don't have any kind of meaning in my life. I'm just sad. I'm out of energy. Nothing is fun anymore. You can focus on that, and you can think that there's something wrong with this person because this person is enabled to enjoy life.
Mhm,
But
mhm.
you can also kind of focus on how does this person interact with kind of the environment, other people. Um, are the kind of skills deficits, like this person really don't know how to take care of himself, herself,
Yeah.
like basic things like how do they eat, how do they work out, how do they like connect with other people
Like
socially.
making sense of feeling down.
Yeah,
So
yeah.
yeah.
It's have, I mean, multiple kind of layers to that, and one layer to that is kind of the behavioral like interaction with the environment. Like if you don't interact with the reinforcers, you don't get reinforced.
Mhm,
But if you kind of for some reason have a kind of a might be temporary inability to kind of feel, I mean, joy or meaning or whatever, uh, people tend to stop doing that. They stop to interact because it's kind of also kind of takes a lot of energy to interact, to be
mhm.
active, to be keeping on track, doing your routines, go to the gym,
Mhm,
eat
mhm.
healthy, I mean, sleep.
Yeah.
So people tend to kind of stop doing that
Yeah.
because it doesn't really pay off.
Yeah. So perhaps this is a good moment to ask, like, can you provide an example of how focused act has directly impacted a client or professional? Like,
Yeah, I think I can do both. I think I can do both. Um, I I saw this older um, woman. That was actually a couple of years ago, but I think that's a kind of one of those moments where Focus Act actually kind of really kind of brought something to the table for this woman. She has been in this huge accident like many years ago. She suffered from PTSD, but she didn't really know that. To her, it was like every day was a struggle. That was kind of a
her
real
new
struggle.
normal.
Yeah, I mean, she's been kind of suffering from PTSD for like 30 years, from an accident where people died, and she really couldn't connect the dots. Like she couldn't see that kind of that loss and that kind of near death experience, and also the shame. She survived, the others didn't. Uh, she couldn't really kind of see that she learned something that day that kind of changed her view on herself, on the world, on other people, on what to expect. So when we kind of, within this first session, we kind of could reframe her, all of her kind of fused perspectives of everything being meaningless for her, like everything is a struggle, everything is a must. There's no joy, there's no choosing, there's no she didn't kind of sense that she had any agency in her life.
Mm-hmm.
She got up in the morning, she got to work, and but she wasn't there. She was kind of on autopilot.
Yeah.
And when we kind of within this interview kind of had her show up with all of these emotions, and she could kind of start to kind of actually embrace them, like this is loss, this is sadness, this is shame, this is guilt. And she could kind of also see where they come from.
Yeah.
They came from that kind of experience that she had like 30 years earlier. I mean, I don't know if that's true or not, but it made sense to her.
Yes.
I can kind of track my experience.
Yeah. It was a
Like,
wow moment.
yeah, it was a wow moment for her. And she could kind of walk out of that session and kind of have the sense that I'm putting this a little behind me now.
Mm-hmm. Mm-hmm.
Because I survived that. And if I survived that, I could survive pretty much anything.
Wow. Yeah. Yeah.
We met once again after that. And that's kind of 30 years of PTSD. And I think we kind of actually kind of wrapped that in within 20 minutes.
Yeah.
And she kind of got it.
Yeah. Awesome.
And I mean, that's an example. It's an extraordinary example. That's not kind of the everyday kind of experience with clients, because it could be a struggle to work
No,
with
but
clients.
I like the example. Thanks.
Yeah,
Yeah.
I think it kind of highlights what's it about. I mean, and you need kind of those kinds of experiences. I mean, when you work with clients, because that's kind of keeps you on track. And you need to kind of see that shit, this is actually making a difference for people.
Yeah.
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 But also for a professional, I had a kind of this pretty young psychiatrist who had a client who was a kind of, a lot of comorbidity, some substance abuse, depression, anxiety. I think there was a kind of a bipolar or something like that also. But at this moment, the client had become more and more suicidal. And this psychiatrist knew that I was working with suicidal clients. So he asked me, could you kind of be co-therapist with
Oh,
me?
you do that a lot, eh?
Yeah,
Like
I do that a lot.
in
I
your
think it's
supervision, you
yeah.
work as co-therapist. Yeah.
Yeah, I think that's a kind of a very, very kind of nice way to do it, because it's going to be like you can kind of sit on the sideline and you can kind of see what's happening, and you can slowly you can go in and you can intervene and you can move out again. So you kind of just changing the conversation, you're changing the kind of the track of the conversation. You don't have to be the main provider, but you can kind of help the other one to see things that you get fused as a therapist as well, or a psychiatrist or whatever. Of course, we get fused, and sometimes we need someone to look at that and see that we are fused. And
Mm-hmm.
I think it's better to do that in interaction with the client rather than having you sitting with
So
me.
you saw that with this psychiatrist.
Yeah, it was pretty clear that he thought that his kind of task here was to prevent this man from committing suicide. He was kind of kind of scared and kind of upset with the idea that he was losing this client. He might die, and it's going to be on my shift as well, and that's going to be kind of painful for me. So he was kind of a bit fused with his own kind of emotional parts and his own rules about committing suicide. So what I did was I kind of just brought the kind of the fact model. Like when we work with suicidal clients, we do pretty much the same. So I brought that to this session, and so I stepped in and I was kind of talking with this man for a while, and we were kind of trying to do the contextual interview. We're doing kind of the problem solving part, where kind of what problem would you solve by not being here anymore? And we can kind of see that was like, yeah, that was kind of a way to try to solve a problem that we also could kind of attack with acceptance. because this was, I mean, emotional pain.
Mm.
This man suffered from a lot of emotional pain, and he was kind of trying to avoid that to any cost, even if it kind of meant that he was going to have to die.
Yeah, the cost of his life. Yeah.
Yeah, yeah. So when we could kind of bring that kind of emotional pain into the room, and he could start kind of interact with that, and we could kind of help him with that, and we could kind of put words to it, and we could model acceptance, and we could work with his kind of posture. He could kind of relax within that situation with those feelings. So it was kind of it's pretty much a exposure therapy in that way, but in a very smooth way.
Yeah.
And after a while, he could kind of see, he kind of moved from kind of this uptight, being scared, anxiety, to he could kind of see the other components, the sorrow, the losses, the kind of the shame of being in where he was in his life at the moment. He started to cry, like the was kind of going from this really hard emotion, like a little aggressive, to being more on the kind of this sad, where he started to cry and actually kind of could kind of embrace that he was hurting.
Mm. Yeah.
Uh,
And this was totally new experience because I assume because before he was avoiding and searching for another solution, and this
yeah,
was
yeah.
a
I mean,
new
that's. I mean,
perspective.
yeah. I mean, that's what's kind of driving most of his kind of suffering was. I mean, the substance abuse, like the rejection of others, the aggressivity, like
Mm.
I mean, he was pretty mean to people around him. He was a kind of that kind of a client that you have a little kind of, oh, okay, it's him again. So that's so the psychiatrist also. I mean, when the client left the room, the psychiatrist said to me, "I'm never going to do suicidal assessment again. I'm never going to do that. I'm going to do this." So that
So he
was kind
signed
of
up for ACT course, FACT
yeah,
course.
yeah.
Yeah.
So that was kind of an example of how it can be changed to professional.
Beautiful.
Yeah.
Beautiful. Thank
And
you.
that's kind of what I meant with it's kind of hard to explain this. I mean, you really kind of need to kind of experience it. You need to be
Yes.
in that room to kind of actually see this.
Yes.
It's not
Yeah.
like we're not magicians in that. I mean, it's not like we super skilled. It's like we know something and we work with that. And we've done that for 20, 30 years. So, I mean, so of course we kind of know that. But if you haven't seen it, you don't know it. It's a kind of a matter of skills. It's not a matter of talent.
Yeah. So let's show the professionals in Holland.
Yeah.
So, and
Uh,
tell me about the workshops. Like, what can the participants expect from the Focused Act Basics workshop?
yeah, the first day there, the basics. I'm gonna. I mean, we're doing this together. I'm.
I'm honored. I'm honored.
Yeah, yeah, me too. Me too. I'm honored to come to Netherlands. It's one of my favorite countries in Europe, actually. Yeah. So what we're going to do is we're going to kind of briefly go through kind of the background. Why do we think this is important? Why does this matter? Why is this worth learning? We're going to kind of touch on functional contextualism a little bit, just what is kind of the base for this? And of course, the theory of focused act. One of the kind of the models that we circulate around is the three pillars. It's like most of the people who's been working with ACT have seen kind of the hexaflex. We try to kind of boil that down to something that's more the kind of clinically easier to maneuver in the room with the client. Like it's really hard to see how self as context is kind of connected with present moment to values to diffusion to I mean this kind of it's a good model, but I think it's a research model. Actually, I don't think it's a clinical model. I think it's a research model. But what we try to do is we kind of focus on three main things. It's the ability to be present, like to actually kind of show up in the room and be present and be in the like talking about things like as they occur. Not
Sorry, a state?
as they occur, like
Oh,
when they show up.
talking about things as they occur. Yeah.
Yeah, yeah.
Yeah.
Rather than talking about things that happened before or might happen later on or happened yesterday, or I mean, So we try to kind of be in the present moment. And to do that, you need to kind of work with openness. I mean, you need to be open to even kind of be open to and present with things that might be painful. Because as I said before, like they are interconnected. So you want to work with things that matters to the client. So of course we work with values. We call that like engagement in ACT, like being engaged. In fact, I mean, so I think that those three pillars, present moment, openness, engage, those are kind of the things we are kind of trying to maneuver. And that also makes things a little, I mean, back to the questions, how can we do this in 30 minutes? Because we kind of compromise the model in that way. It's kind of compressed down to this, because this seems to matter. I'm not sure it matters if you actually kind of see that now I'm working with self as context, and now I'm doing diffusion, and now I'm doing values. I'm not sure that that really matters. I think that might be matters when we learn, like when we try to understand the processes. But when I work with a client, I mean, it seems like we need be more on target, more like right on. And
are you here? Are you here now? Are
Yeah.
you, aware of what's happening? Can you
Yeah.
let it happen, and can you focus on what's important?
Yeah. Well, I mean, within all of this, in this context of all of the emotions, all the memories, all the physical sensations, all the worries and thoughts, I mean, could we kind of focus on this?
Cool. And Thomas, how do the skills building workshop and the workshop on traumatized and complex clients
Yeah. Yeah.
build on these foundational principles of focus
Yeah,
act?
just let me end this first one, because I'm not really done yet.
Oh, excuse me. Excuse me.
I'm,
The rude
I,
Dutch
I,
guy.
I'm a bit talkative to be kind of focused right now. It's late in the evening. It's been a long day.
Oh, I love it, man.
Yeah,
I love it.
yeah. But back to that. So I think you also asked me earlier on, why does this matter to professionals, and why is it kind of relevant? I think it's relevant because it's logical. So if you can learn those three pillars, and you can kind of understand how they are kind of driving both the suffering, but also what we need to do as a clinician. If you can kind of grasp that, and you can learn the interviews. I mean, you could actually see clients the next day, and you can make difference for them.
Yeah.
So I think you can be better at it, of course. So, I mean, 1 year later, you're going to be more skilled doing this if you train, but you can actually do it the next day.
Yeah. Awesome.
Yeah, so I think that's why it's relevant. And I think also you can do this as like a medical provider. I mean, you're prescribing maybe psychotropics, but you can do that within a frame where you also do this. So you don't have to become a therapist to use focused act. That's kind of one of the things that I think I mean, in advance for focused act. It's not bound to psychologists or social workers or psychotherapists. It's more like within this frame. You can do physiotherapy, you can do nursing, you can do like medical
Teaching.
teaching. So I think that's so it's a kind of a transparent model in that way.
Yeah.
It's like fluid in that way.
Yeah. Cool.
Yeah.
So let me ask you now, how do the skills building workshop and the
Yeah.
workshop on traumatized and complex clients build?
Yeah, the second workshop, it's going to be skill building. It's kind of a next level. I mean, the first day we're gonna teach it. We're gonna show it. They're gonna have a kind of a little kind of training around it, a little experiential workshop in that way. Day two will be heavily focused on training. Like I'm going to be better at doing this when I visit the second day, because it's going to be more around me as a clinician doing focused act, and not so much about Thomas and Jan teaching. It's
Cool.
going to be
Cool. And what skills do the participants take home after the workshops? So suppose you who are watching or listening attends like all three workshops. What do they take home?
I hopefully they take a complementary perspective that complements what they kind of doing already. It's not like this is not overruling all of the experiences. On the contrary, I think you can use a lot of your traditional therapy skills or provider skills within the framework of Focus Act. So it's a kind of another framework to do what you're already doing, but more focused. So of course we're going to add a lot of skills because it's kind of also kind of a separate model. So we're going to add a lot of skills and perspectives to that. But I mean, it's not like you have to stop being that cognitive therapist or this cognitive behavior therapist or this affect focus therapist. I mean, it's going to be perfectly fine to take the skills that you have from your original training and to put them into this framework.
Yeah.
So I think that it's going to provide like more openness, I hope, for the clinicians who attend in how they can use their skills.
Cool.
Clients.
Cool. And is there something to say about what makes these 3-day workshop series a unique opportunity for professionals who are already familiar with ACT? Like,
yeah, I think because it's going to be, I mean, there's going to be kind of something that connects all of these 3 workshops. I mean, there's going to be like Focus Act is kind of, I mean, the highway through all the 3 of these days. When we come to trauma, it's going to be also, I mean, trauma is not a thing. It's not like trauma. I mean, trauma is not a diagnose. It's
it
a
doesn't
learning
fall from a
experience.
tree.
Yeah. Yeah, it's like a learning experience. Like I experienced something that changed a lot of kind of my perspectives. And for a lot of people, that is kind of suffering in many ways. For a lot of people, it's raising their kind of stress level. It affects their physiology because if you have a constant high stress level, you're going to have a lot of high cortisol. It's going to affect your metabolism. It's going to drive inflammation in your body. I mean, this is kind of affecting you in a way, and you don't really know from person to person what is going to be kind of the main target. For some people, acceptance is kind of the thing. We need to work with acceptance. For other people, it's kind of skills. For some people, it's behavior activation. For some people, it's kind of reconnect with the world, reconnect with other people, reconnect with intimacy or whatever. So that's kind of the part that's kind of open. That's the intervention part. We really don't know in advance what's going to happen. I mean, we know that prolonged exposure, for an example, that works for a lot of people, but it's also a model that is so demanding that most clients actually quit.
Yeah.
But for the few who manage to go through all of the treatment, the prognosis is really good.
Yeah. So you're talking about the complexity.
Yeah, the complexity
model.
in what we're going to work about in the 3rd day.
Yeah.
So it's also kind of a build on. I mean, it's going to be more complex. I mean, the 3rd day is going to be more challenging for the person who attend than the 1st day, because we will kind of set those skills that we are learning in 1st session, training in day 2. We're going to set them kind of in motion with complex situations and complex conversations.
Yeah.
Because I don't think that there's such a thing as a complex client. Clients are kind of, they are doing what they are doing because they are trying to kind of survive. And we can kind of see that as kind of odd or weird or complex or hard or whatever. But actually, it's conversation that's complex. You need to be kind of flexible as a therapist to change your conversation so it does the kind of. I mean, you need to target things, and you don't know in advance what to target. So, I mean, the 3 pillars is also they are kind of the guidelines for us, because I need to be present. I need to work out of values.
We're not flexible.
No,
Get it?
no. I mean, we're people.
Yeah.
and
But if we can't make ourselves flexible again, if we notice that we are rigid.
yeah,
Yeah.
yeah. So I think that I mean, we are people as the clients are. I mean, there's more that's common and more that's kind of similar between us than are different between us.
Yes.
We are trained, they are not. They might be trained in something else, but we are trained in this. So I think it's and since we are kind of human beings, we are beautiful, but we're also flawed in the same way. I mean, we are just what we are. So I think that's kind of also kind of the one of the things that I think comes with all of this kind of non-expert position. Like it's a kind of a humane way to you need to kind of be soft on judging. You need to be open to that things that you might not think gonna work might work. I had this client, I saw this client for like 2-3 sessions, and she came back and she said that I'm done with this. I went to this dancing. It was like some healing dance. I went to this dance, and it was kind of a whoa moment for her. She was like, I don't need this psychology anymore because I found this dancing. And I was like, whatever floats your boat. Yeah. So I also think that because we are also, I mean, that's a kind of the other side of being engaged. Like I mean, most of us as clinicians, we are kind of invested in helping people.
Yeah.
So we want to see change.
But what pops up in my mind is like being open for whatever works.
Yeah. Kind of that's the one part that's really kind of heavy in focused act is the workability.
Yeah, workability.
If it works, it's true.
Thomas, I can't wait.
It's not true. Yeah.
I can't wait for May.
Yeah.
So suppose somebody is watching or listening and they're like, they're considering signing up. What would you say to mental health professionals who are considering to signing up?
I mean, I went to a workshop in 2002. It wasn't a fact workshop because we haven't invented fact at this moment. It was an experiential workshop with Kelly Wilson. It was a 2-day workshop in 2002. I've read a book. I've been trying to do things by the book. I went to this workshop and my life never was the same after this. It kind of moved me in a way that I didn't have any idea was possible. That might not happen for everyone in those workshops, but it could happen.
Yeah,
it could happen.
So there's the possibility of a wow moment.
I hope so. We usually have quite a few.
Nice. Yeah, I know. I'm super excited. Yeah. Thomas, thank you so much for having this talk. I really enjoyed it.
Yeah, me too.
Nice. And to all of you who are listening or watching, thank you for tuning in. Yeah. And if you are as inspired as I am by what you've heard, don't miss the chance to deepen your understanding and skills and knowledge about Focused Act. Thomas and I are thrilled to be hosting a 3-day Focused Act workshop this May 2025 in Utrecht, my hometown, Netherlands.
That's going to be really cool. I'm looking forward to it.
Cool. Yeah. So if you want to subscribe, read more, look at www.practicalact.com or email me, jan@practicalact.com. And yeah, we hope to see you in May.
Certainly do.
All right. Bye.
Bye. Thank you.